Okay, Assalamu alaikum wa rahmatullahi wa barakatuh, and good evening to all colleagues and friends in UAE and the Gulf and the world to this, I think, special meeting. I'm sure you are used to our meeting societies of Emirates, different specialties. This is number 10, so we are meeting today with the true, you can call it frontline, the Emergency Society of Emirates, and we have the heads of the major departments and hospitals in UAE, government and private. And it's always great to have them with us to hear the story, hear the journey they've been through it. And I think it's after 4 months of COVID experience, and to tell us what they've seen, what they had, and I think everyone spoken to will be delighted to be with us on this meeting. So on behalf of Emirates Medical Association Board and President Dr. Moza Sharhan and new Emirates Medical Journal, would like to welcome you to this special meeting. You can see you've already seen the panelists and the speakers for tonight. We have Dr. Saleh Faris, the President of the Emergency Society of Emirates, and we have his board members, Vice President Dr. Mahmoud Onaim, used to be cardiologist. I think he's still cardiologist. He's the head of the department of Dubai Hospital. And we have Dr. Sam from Qasimi, major, from North. You can call it MOH, all the MOH hospitals, this is where they refer all their patients to. And we have, of course, Tawam Hospital, which is taking the major role in Al-Ain for all the patients of emergency. And we have Dr. Kobersi from Cleveland, Abu Dhabi. So without further ado, I'd like to welcome Dr. Saleh Faris to tell us about his society, his members, their activities, and then his presentations, unique presentation about this, and then we'll take it from there. Then at the end, inshallah, we'll have your questions and comments. They'll be dealt with. Please write your questions and comments, and we're expecting to be really an interesting, eye-opening, I think. Dr. Saleh, we are looking forward to your topic. Please unmute yourself and you can start. Thank you.
Bismillah ar-Rahman ar-Rahim. Can you hear me? I guess, yeah. Thank you so much, Dr. Abdullah, for a great initiative, and thank you for EMA for the great invitation. I'm actually very humble and proud to be with the leaders of emergency medicine who truly help the healthcare and the frontliners in emergency care across the country. I think we have much to offer today from my colleagues. I'll just be, I think, giving the national side of things. As a society, we've been there for a couple of years since 2012. I'll try to give a little bit of overview what the society, what did we do. But before we go into that, I'll just move my slides. I have nothing to disclose on this presentation. I'll just go briefly over the healthcare, the emergency healthcare system in the country. I'll give an overview of the Emirates Society of Emergency Medicine and some of the activities and achievements that we've been able to achieve over the past couple of years, and what did we do or we tried to contribute from a society point of view. I think everyone was challenged by this pandemic, but we tried to contribute as much as we could. So just very briefly on the emergency healthcare system in the country for those who are from abroad. The UAE is 7 Emirates. So we do have a couple of regulators in each Emirate. So the Emirates, if you look at the Emirate of Abu Dhabi, which is the biggest, is more of regulated by the Department of Health of Abu Dhabi. Within Dubai, we have the Dubai Health Authority, and in the Northern Emirates, it's run, as Dr. Abdullah mentioned, by the Ministry of Health as an operator. This plays definitely a good, important role of learning from each other, but at the same time, challenge of coordinating some of the efforts. For those of you who know NCEMA, this being a leader in this pandemic response, this is the National Emergency and Crisis Management Authority. Basically, what they do is just they oversee all the emergency responses in the country, not just within the healthcare, but more of the different sectors. They have different levels of responses, 4 of them. So if it's local, it is mainly at an emirate level, it's called level 4, but if it could go up to level 3, level 2, if it's national, and as it go on to what we've seen, that was a national response. In 2014, we managed to publish what I consider a landmark project that we've done back in 2009, but we published it in 2014. Basically, this was my fellowship project. What we did is we studied all the Abu Dhabi hospitals, their disaster plans, sort of different responses. And what we actually compiled it with different experts from the world. And we came with a couple of observations, which I think, alhamdulillah, I hope it really helped by shifting our response in Abu Dhabi, in the healthcare, at least within the hospitals, from a hazard specific to all hazards approach. And this prepared many of us. So we also commented on the command and control within the hospitals and the healthcare sector. This is more, the third point is the HVA hazard vulnerability analysis, which is basically an analysis of all previous disasters and how do you learn from them. We commented on the collaboration, the communication, the hazmat, and this was a key component, how to prepare hospitals for pandemics, outbreaks, and chemical outbreaks. We also commented on the emergency management sort of programs, how to organize disasters and response. This is a system that we introduced back in 2009, which called the Hospital Incident Command. And this was mandated in all Abu Dhabi hospitals, and alhamdulillah, it helped organizing the response within the healthcare sector at a hospital level at least. There are so many national committees at an emergency response over the past couple of years. So this really helped coordinating the response within the healthcare and emergency healthcare sector specifically. We've been very blessed by the support and the leadership we had during this response. His Highness Sheikh Mohammed bin Zayed, His Highness Sheikh Mohammed bin Rashid, they've been on top of the response and really supported, and this really motivated a lot of the activities. As many of you know, I mean, the command and control was really well coordinated. There are obviously many challenges, but I'm sure the information sharing was really, I think we're very proud of it. The disinfection program, which is actually a curfew in terms of restricting activities in the country, the enforcing of social distancing, restricting of travel, and the national screening program. I think we've been the best country or one of the leading countries in terms of screening, and this really changed the whole thing. From a healthcare and emergency sort of system, the field hospital really offloaded a lot of the influx, because any patients we see in the emergency department need to be admitted, sometimes and most of the times are transferred, and this will be shared by my colleagues from the different emergency departments. The communication, there was a clear messages, sort of weekly, if not daily briefing at the beginning, which really sent good messages to the community. The public awareness campaigns were also very well, and this helped decrease the stress of the community, making sure that the response in general, and even the patients that we see in the emergency departments, many of them were educated by such public campaigns. The motivation of the healthcare workers, and we are one of them, were really evident through different campaigns by the government, politicians, media, and this really helped the community as a whole. So I'll leave the emergency sector specifically, but I think I take this opportunity, they're not represented here today, but honestly, the paramedics and the pre-hospital care provider who've done an amazing job throughout the outbreak and the pandemic, they really did an amazing job of transferring patient pre-hospitally and even inter-facility between hospital to another. I'll leave my colleagues, as I mentioned, to talk about their experience in the different emergency departments. But we were really helped as an emergency department specifically. This was more of inpatient, but at least having the national guidelines truly helped and this was frequently updated. Obviously, this was a challenge to them, I'm sure, the authors of this guidelines, but the different evidence, the different practices really needed someone to capture all of this. What is the best evidence out there, and what should we do? From an Emirates Society, we call it short as ESIM, the best or the least we could do at the time, everyone was swamped and busy with the pandemic response. So we tried to capture some of the best practices worldwide and recommend as a position statement. So we presented this as, it was one of the publications. We had multiple webinars. This is a speaker, Dr. Ma'moon from the UK, and critical care. He shared his experience. And also we we co-endorsed the president of the World Association of Emergency and Disaster Management, WADM, Professor Gregory Seaton from the Harvard University. And also we hosted Dr. Catherine Henderson, the president of the Royal College in the UK, and Professor Yves Hablo, the chair of the UZ Brussels Hospital, one of the biggest hospitals in Brussels. So we shared a lot of experiences, and we tried to learn as much as we can. We collaborated also with the Dubai Command and Control Center. We organized multiple webinars to them from different parts of the world, tried to share many of the experiences. Obviously, it affected us directly, and we are switching to a virtual conference this year, and hopefully we would like to invite all of you to participate. Dr. Abdullah, you asked for a brief overview of the society. I'll just try to give it a minute or two, and I will end with this. So the society established in 2012 by, honestly, I always say that those were the heroes of emergency medicine and continue to establish the specialty in the country. We have multiple activities through Ramadan, social activities, outreach programs. We go to smaller cities and even villages sometimes to teach emergency medicine to the smaller departments. We host multiple conferences, multiple courses. We conducted multiple courses internationally in Egypt, for example. We try to participate in different national, this is Dr. Rasha participating in the UAE Youth Retreat by His Highness Sheikh Hamdan bin Mohammed bin Rashid, and also multiple events and activities. Alhamdulillah, our conference became over the past, I would say, 6 years as the largest emergency medicine conference in the MENA region. We reached, alhamdulillah, over 1,300 participants. Unfortunately, this year we're going to go virtual, as I mentioned, but hopefully next year we will try to do much better. We're trying to contribute to the community. This is an initiative from our society to introduce the Good Samaritan law. I've been talking even yesterday about it. So alhamdulillah, it's moving slowly but surely. It took us some time, but this was a kickoff by our society. We are participating in a stroke program, trauma program, and different activities within the country. Alhamdulillah, we have very good relationship with the government entities to collaborate. We have good respect. They always reach out if there's any activities that they would like to help with. And finally, our conference has been, as I mentioned, alhamdulillah, very active. We try to focus on major skills and activities to try to build for our residents, for our emergency. And we always try to focus on how to build emergency medicine as a specialty, understanding that not every department has specialized or board certified emergency physicians. Airway workshops and different workshops. Alhamdulillah, we've been participating with multiple activities with the International Federation of Emergency Medicine, the WHO hosted. We have a monthly newsletter you can subscribe to, and we have very good relationship with the international societies. We participated with multiple activities also with different societies in the UAE here. And alhamdulillah, we won the biggest conference in the world in emergency medicine, which will be hosting next June, inshallah. So this is a brief overview of what the society tried to do over the past couple of years, but also during the COVID. And I will leave it at that if there are any questions. Thank you so much.
Outstanding, Dr. Saleh. Beautifully presented your, I think, very active society of events and activities and the roles you played, and as you showed us at the high level. And as you said, everyone is going virtual nowadays, and you can see we are reaching you guys through this meeting. So I think so far I think that's fine. I think you can go ahead and introduce the second speaker, Dr. Saleh, and you can take it from there.
Sure. I think thank you, Dr. Abdullah. It gives me a great pleasure to introduce my colleague and my friend and my mentor, Dr. Mahmoud Ghanaim, who's, as Dr. Abdullah mentioned, he had a long career in cardiology, but we converted him to an emergency physician, a few years ago, and we had the pleasure of working with him. He's the vice president of our society, and honestly, one of the leaders of emergency medicine in the country. I cannot imagine myself working in Dubai hospital during COVID, I think, but he did it. He did an amazing job, and I've been talking to him day and night and weekends, and he was always in the hospital. So Dr. Mahmoud, if you want to share with us your experience, please.
Okay, thank you very much, Dr. Saleh. Let me first. Actually, I have a fish memory, so I forget how I did it yesterday.
If you go to share, I think down there.
Can we choose the PowerPoint? Can you open PowerPoint now?
Sorry, give me 1 minute. Oh. So share screen, and then.
Can we open the presentation first?
Sorry?
Could we open the presentation first?
Yes, 1 minute. Yes, now it's open.
Now we can share screen from Zoom.
Disappear.
Right.
Okay, share screen, and then here we are.
Great, thank you.
So, I'm sorry,
Okay, make it bigger and go ahead, Doctor.
Okay, so thank you, my colleagues. Thank you, Dr. Saleh. I think it was a great presentation as usual, and I always learn from Dr. Saleh, honestly, and I cannot myself imagine emergency medicine in the Gulf, not only UAE, without Saleh Faris. So I am working in Dubai Hospital. Actually, Dubai Hospital is one of the two main hospitals in Dubai, and we have one of the busiest emergency departments maybe in the area. Our daily was around 350 to 400 cases per day, and it is really a tertiary hospital which is extremely busy. But the challenges when we sat together first, I started actually to develop a team in 28 January 2020, when we had our first case in Dubai Hospital, COVID positive, was admitted to ICU, and then the tap opened. So the thing was try to adapt to the ever increasing flow of patients. When we sat as a Supreme Committee, they were talking about 5 to 6 cases per day, but our leaders told us be prepared for 100 to 200 cases per day. Our emergency medical services for sure had prominent role in the triage of suspected patients, and we were trying actually to be the screen area first. And we know that at that time it was vague. We don't know the global burden and what will happen. And we know that emergency physicians are at the forefront, and reports show that our clinical work was a lot more difficult, and though it was not easy already. So, and after all, there was the risk of potential contamination, risk from the effect of extended shifts, and the hospital of being away from the family. And I can tell you that for 4 months, we had no rotas. Actually, everybody was almost there. I think that also we thought we'll have universal masking. Everybody should write his name, because with full PPE, we don't know each other. Maybe I was known because I was quite obese at that still. So everybody knows me by my weight. But you have to write your name in your PPE. We have to create special waiting areas, because even one patient, although we transfer to being a COVID hospital fully, but still the ER was peculiar, because some patients who are coming not COVID should be separated in separate waiting areas. And you know the concern of these patients that they will be infected themselves. Frequent cleaning and disinfecting, and I can guess that I was disinfecting my hands every maybe 15 minutes or so. And you have to keep social distancing, but we were very close to each other, especially when we resuscitate patients. So this is me, and I can tell you that this was my uniform around 20 hours per day in the emergency department, and also my colleagues used to be like this. We spent the whole Eid in the emergency department, and Alhamdulillah, you know, they came and took photos. This was encouraging, actually, that we were during Eid in the emergency department. This is a real statistic, and it showed that, imagine that in the month of January, our daily visits was around 9,500 and then 9,000. In March, we started to decrease, and then you can see what happened in the peaks of COVID. April, May, and June, that our visits, these are non-COVID. So you can see that it decreased by around 40 to 50%, and this is another figure to show the real drop in the non-COVID emergency visits. It's 60% decrease, which is really amazing. And we were not away too much. You know, if you take comparison, this is what's happening in the United States. They had 42% decrease on emergency visits. It declined by 42%. What happened if you take the same dates? You can see that our visits declined by 53%. So this is a dramatic drop. And what was worrying us, that some serious cases which should have been coming to the emergency department, also the visits decreased. So we were wondering where those patients go. For example, the ST elevation on my cases, especially in the month of April, dropped dramatically compared to the month January, February, and even March, but now started to build up, which showed you that during the COVID, honestly, we may have lost so many of ST elevation on my strokes or serious diagnoses like diabetic ketoacidosis and blood pressure. Luckily, Alhamdulillah, the team quickly made changes to their process to meet the challenge of caring for patients with COVID-19, while they continued to care for their patients with other urgent care needs. It was a matter of organizing the team, those who will deal directly with COVID patients, and we have to keep sub-physicians who are clean, who are not exposed to COVID patients, to care for those who are non-COVID. But still, these physicians were afraid that, we were preoccupied by the idea that anybody who entered the ER is COVID-19 till proved otherwise. And all of you know that the list of symptoms were increasing. So started with breathing difficulty, fever, headache, throat pain, then any vomiting or loose motion, then loss of taste and loss of appetite, generalized body pain, lassitude. All these were labeled as symptoms of COVID. And imagine so many patients who are non-COVID, these are usual symptoms for them. And emergency physicians were so precious that they want them everywhere. So in the top picture, we were requested to participate in Dubai Field Hospital in the Trade Center. So we sent so many nurses, so many emergency physicians. We have Al-Rahaba Isolation Center where we send nurses and emergency physicians. And then we have Warsan Isolation. And you can see that when I'm talking to you about Al-Rahaba, don't think this is a ward or a floor. You can see how many buildings. And you see Warsan, how many buildings. So emergency physicians were the most wanted at that time. So I was hoping that we can clone our emergency physicians. And you can see that in the ER, especially for we were in our emergency department in Dubai Hospital, we shifted almost to a mini ICU. We have so many intubated patients that we have to care for them in the ER. Not only intubating them and shifting them up, but care fully for them in the emergency department. And we use the corridors, we use every single place or centimeter in the emergency department. So we have to shift to ICU care in the ED. So we are not anymore emergency physicians, but we were also working with intensive care, which I call really, this is what is called acute care and acute medicine. And at that time, actually, we used this is our sleeping time. Only you can have a nap. There's nothing called go home and have a sleep for 2-3 hours. And this is me, but honestly, this was after a very long shift. But what was amazing, honestly, not only in Dubai Hospital, but all over UAE was the teamwork and the high morale. Everybody did it with a smile. Everybody did it and he's happy. And this is the credit UAE took internationally, that everybody was doing it because he wants to work, he wants to help. My list of volunteers was really thousands. Everybody wants to volunteer. And it gave us also, you know, ideas. Maybe some ideas were there. We learn to adapt. We learn to innovations. So for example, we were trying to just modify the intubation books for the safety of our colleagues and physicians. And then the drive came, you know, with words, for example, Sheikh Muhammad, who talked to everybody, and we feel that he is talking to us directly, personally. So we have no choice but to do it very efficiently. Nobody forget us. In between the prolonged shifts, they used to feed us. That's why I gained weight, by the way. And actually, this is my picture in Dubai, Dubai Mall. I never been to Dubai Mall physically, but apparently now I am there. So how I can tell that how I will not do it, how I will not give the best I can do. And I will show you that this is the sleeping positions. Engineer, teacher, and programmer, you can see what is the sleeping position of a doctor, especially during COVID. There's no sleep. He's awake 24 hours. At the end, all these difficulties did not stop us from winning. And honestly, we won. This is me with my COVID team leader, also co-COVID lead teamer, Dr. Amna Limheri. By the way, she's a hematologist, but now she is an expert on COVID management. So actually, we are proud that we did it. And we are proud that the emergency physicians in the whole UAE, because we were, you know, contacting all our colleagues, were heroes. We changed the mentality that emergency physicians are referral physicians to the fact that the emergency physician is the most precious ones. Now, honestly, Dr. Abdullah Shab, sorry for that. I am proud to be an emergency physician now, though I work in cardiology for 22 years. So thank you, everybody. And I could have, I think I gave a short summary about what happened, at least in Dubai.
Outstanding, Dr. Mahmoud. I think since you moved from cardiology to ER, you become an expert in presentations, and mashallah, so beautiful. The data so outstanding. To be honest with you, I think this is what we need. I think this is the whole journal looking for this kind of experience to be published in our journal, inshallah. I think we are doing fine, Dr. Saleh. We can go, running slightly out of time, so we can introduce the third speaker.
Thank you, Dr. Abdullah. Thank you, Dr. Mahmoud, for another very outstanding talk. I would like to introduce my colleague, Dr. Assam Zarouni, who has been a pediatric emergency physician trained in Canada, one of the leading emergency physicians in the country, and he's taking a leading role in the Ministry of Health, development of emergency medicine in multiple hospitals, but he's taking the leading role in Al Qasimi, which we know is the biggest hospital in the Ministry of Health in the Northern Emirates. And I cannot wait to hear his experience. I've heard so much, but I think hearing it from him will be different. Dr. Assam, please.
Thank you very much, Dr. Saleh and Professor Abdullah. Thank you for giving me the opportunity to be among you distinguished colleagues and to share our experience with the audience who are participating today and among us. I tried to be as brief as possible in my presentation, so I hope I will not take much of time, and I'll try to stick to the facts. So if you give me a minute. Okay, so I am the head of the emergency of Al Qasimi Hospital, and I am also a coordinator of 3 different teams created by the Ministry of Health during our preparedness of the disasters. So we have 3 zones that covers the entire Northern Emirates after Dubai, and each zone has a leader and a coordinator, so that we coordinate our response to any disasters, and pandemic being one of them. So this helped us a lot actually in response, or in our response to this pandemic. Now, we started at the beginning with a lot of uncertainty. That's what Dr. Mahmoud referred to as the beginning also. So we were supposed to be a non-COVID hospital, or we remained also to be a non-COVID hospital. But, there was a lot of, okay, what is this virus? What is going to happen next? Do we really have cases? Do we have really sick cases? What we're going to do with the sick cases? That's when we started to walk into this pandemic. And at the beginning, we didn't see many of the cases. So to some extent, our emergency was in the chill phase. And I was constantly after the team saying that, please be prepared, because we might get ahead of a wave of a surge at any time. So we spent some time trying to prepare ourselves with the different modality or methodology that we had, whether it is preparing equipments, redesigning the emergency, and so on. And it took us a lot of time actually to rethink of how we're going to do with this pandemic when it's going to hit us. So by March, or by mid-February, we started to see cases in our emergency department, although we were supposed to be a non-COVID hospital. So then we thought that, okay, it would require us a bit more also to coordinate. So we created a task force in the emergency department, and to take some actions on what's going to be our response and what kind of practices we're going to follow in the accident and emergency. This was in collaboration with our medical director office and the infection control team in the hospital. And we also had constant communication with MOHAB, or at MOHAB level, especially with the preventive medicine. So then we started to get these cascades of guidelines that Dr. Saleh referred to. that try to unify the practice, have a unified approach towards how to define cases, what to look for, what kind of investigation to do. And we as an emergency, being part of that, started to adopt that. And sometimes we had to modify certain things because it doesn't suit our setting in our accident and emergency, but we were going along with the national and international guidelines. Then we reached a stage where we had to do certain modifications, and this didn't happen only at the emergency of Al-Qasimi, but across the MOHAB facilities. So we restricted the access to the accident and emergency, and we actually were very successful in doing that. And I was actually glad and happy with the way people took it serious, whether it was the public actually who took our instructions serious or the people who are implementing on the ground. We restricted the visitors to almost zero unless is highly needed for the critically ill patients. We started to have the gate entry, a mechanism to separate the infectious cases from non-infectious cases. I'll show you a map. We also reduced the overcrowding to our accident emergency by triaging out those who are not acute cases to our surrounding PHCs or periphery healthcare centers. And also our colleagues at the periphery healthcare centers modified their practice so that they can take these cases and communicate with us in case any of them actually have some illnesses needs to be dealt in the emergency. So what we did first, we redesigned the whole area of our emergency. The way I designed the emergency at the beginning is that we have the hot area, which is the red zone, yellow area, which is the treatment area. The red zone is going to be our resus area, and then the green area is where you see the mild and cold cases. So we created two axes. I don't know if you see my arrow. So if the patient, we first made one entry, and then as the patient walk in, we triage them. If they are infectious symptoms, we immediately put them in this side of the emergency, which is a contained and closed area, so that they don't cross-contaminate any other non-infectious patients. And all of the other patients will go right to the right side, whether to the resus or to the treatment area from the back. And then if we needed to move the patients to radiology or to imaging department, we made a different access for the infectious versus the non-infectious, all well controlled by our security. Now, at the beginning, we were getting 1 or 2 cases. So we were saying, okay, if we get 1 case, that's what we're going to do. If we get a 2nd case, that's what we're going to do. A 3rd case. So we have been able to manage up to 5 cases. Then we are talking about the beginning. And then if we exceed the 5 cases, we have to have open other areas of the hospital itself. So that was our beginning. We also increased our bed capacity. Mahmoud said we had to use everywhere in the emergency, including corridors. And I will add to what Dr. Mahmoud said, we used in the ambulance when there was actually no room for doing it, but that was when we hit the peak, the real surge. We also redesigned our walk-in ambulance and referral cases. So we made a flow and a chart to deal with each category of the patient so that our nurses, triage nurses, and doctors during the busy hours are not confused, and they have a more guidance on what to do with each case, and to the extent that possible with group of patients if they arrive. So this shows our flow chart. It tells our gate entry, which is a triage nurse and a doctor, what to do with each category of a patient and how to dispatch them within the department. I'm going to show some of the data, and I think they are similar to what Dr. Mahmoud mentioned. Our visits actually declined 21%. So I see that Dr. Mahmoud had almost double of that decline. This has 2 main reasons. One, we could not shut the door to everybody because we were the only referral center in MOHAB that has many of the services that other emergency departments or other hospitals don't have. That's one of the reasons. But we have seen for sure a decline in the number of the visits to the emergency. Some of them were controlled by us by triaging out, and others were by the public avoiding to come to the emergency department. Also, as Dr. Mahmoud mentioned, we noticed a dramatic decline in the cases of MIs. So at the beginning, I was discussing with the cardiologist. I'm like, is this something related to the lockdown, or is it something else going on? And I think our cardiologist mentioned something, and I don't know if it was a true fact or it was kind of a sarcastic statement, but we thought that the people at the beginning of the lockdown had much reduced in the stress, and the stress being one of the elements of bringing the MIs, that might have been a factor. But for sure, there are cases who got delayed and arrived to our emergency missed or very late, as I'm going to show in another in other slides. The other thing that I personally was surprised with is that with the lockdown, we still could see really major polytrauma. Because I thought it's going to be a lockdown, people are going to be chill, they're not going to drive fast. But unfortunately, we were still seeing really serious polytrauma cases, although it was less than what it used to be before COVID. We had a 21% increase in our acuity, and you can see that, and that went up, as Dr. Mahmoud mentioned, all the way from February, and it reached a peak during the May, as we're going to see. And we had a prolonged length of stay of our cases in the accident emergency. This was because the policy that we followed is that anybody who gets admitted to the hospital needs to be screened, and then they will be parked in one of the two large wards till we make sure that they are negative, because we didn't want to mix them with all of the other services that we are providing in our hospital. So that prolonged the stay in the accident emergency, waiting for the results, in addition to the workload over the hospital in general, which led to shortage of beds. Now, we saw the surge in our cases in April to May. That's when we actually started to see ourselves as a COVID hospital, although we were supposed to be a non-COVID hospital. We no longer could do much of a separation, because we will see a lot of critically ill patients in the areas that they were not supposed to be to. But thanks to Allah, the team could manage all of them, and as we are going to see, the rate of infection among our staff was very low. Now, this is another interesting fact, that the number of the patients there was a surge in the bodies brought to our emergency. I don't know, not everybody practiced this, but in the Northern Emirate, when somebody dies outside the hospital, they bring them to the hospital to declare the death, and then the police will take the further steps. We saw an increase in the number. Now, when I did some analysis for these cases, not all of them, around 50% of them were non-infectious. They didn't have anything to do with infections. So that's why we are wondering, as Dr. Mahmoud said, whether there were a delay in the cases of MIs and a stroke and others, or to reach our facilities and healthcare, and that's why we had a surge in the cardiac arrest outside the hospital. Now, there was an additional factor that, which is one of the challenges that we faced during the pandemic, is that the mortuaries around us in other two hospitals, because they were COVID, they were not taking the non-COVID patients. So that's why the load came to our hospital. So the role of the accident emergency was very crucial. We were the gateway. We were the one to have to identify the suspect cases from non-suspect cases, which is at the beginning was really very difficult task with all of the conflicting information that we used to get. In addition to that, we were doing our main job, which is stabilizing the critically ill patients. And then we became, unfortunately, at certain period of the time, the dumping area. So anybody who didn't know what to do with any case would send them to the accident and emergency. And then I had to take the burden, or we had to take the burden on to redirect them again to the proper, flow of care. And then later, when we started to chill off a little bit, or the cases declined, we were doing a lot of screening cases, which is screening for the cases, which is actually not the core business of the accident and emergency. Some of the challenges we faced, increase in overall demand due to the surge in the critically ill patients, the high demand versus the low supply of the PPEs. So that's why we had to do a lot of modification to wisely use our PPEs. Shortage of some of the consumables, like that you didn't count for, like the tubes for the high flow oxygen machines, right? And then the load that we had on our oxygen supply. Now, thanks to Allah, none of them did to a catastrophe, or we came at the point where none of them were available, but it put a lot of pressure on us, and it made us anxious because we were constantly in the low level of these consumables. An interesting point that we learned during this COVID is that the oxygen load. As you all know, there is a central supply of the hospital and then the cylinders. Now, everybody thought at the beginning, okay, the number of the ventilators I have, right? How many I'm going to intubate, but nobody thought that these intubated patients and the patients who are on high flow will need oxygen. So what we noticed that once we started to having all of these patients who are intubated and on high flow, the demand on the oxygen became so huge to the extent that it was alarming and it could lead to failure. So that's something I personally learned from this pandemic, is that the supply of the oxygen usually calculated based on what 10 to 20% of your patient population being critically ill on a ventilator. But when you reach to the extent that we reach, where you have almost 100% of all your patients in the emergency are sick or in the hospital is sick, you are going to have an oxygen issue. When we come to the clinical part, the frequently changing guidelines made the teams confused, and it needed a lot of effort. So as Mahmoud said, we spent 25 hours of the 24 days of the way in the hospital. One of the things we used to do is to meet constantly, morning, afternoon, noon, afternoon, night, to look at the guideline and see where we are standing from the treatment we are providing, because we were the gateway. So we had to make sure that we are starting the patient on the right treatment. Otherwise, they can be lost during their journey in the hospital. The other one we face is the late presentations. So patients who were waiting 6-7 days, and then they reach us very sick, and we face a lot of challenges with those patients. And then the other thing I face is how I'm going to intubate the suspected cases, okay? Because the emergency is designed with non-negative pressure, and there was a challenge with the aerosols generated out of the intubation. So we faced a huge challenge with that, but thanks to Allah and the team effort and the teamwork, we succeeded in intubating without getting much of rate of infection. When it comes to the staff, we had at the beginning a lot of anxiety of what we are dealing with, what kind of workflow we are going to have, and so on. That eased up with time, and with a lot of positive messages from our leadership, team collaboration, and then the educational activities that we did to some extent among our team. The other thing we challenged, now Dr. Mahmoud mentioned about the precious physicians. I'll take you about what was more precious than our doctors were our nurses. So everybody was asking for the nurses from accident emergency, because now there was a huge demand and load over the ICUs. So we had to allocate our nurses to certain areas, whether it was due to the expansion or due to coverage of the ICUs. And we used to get nurses to the emergency as a replacement, those who are not actually trained to deal with critically ill patients. So we had to put them through training again, so that they have at least an insight of what we are dealing with in the emergency. And then the last thing we had faced is the infection, but among those who are actually the supporting staff, like porters, cleaners. And most of this happened from outside the hospital, so not from, from our emergency. We also ran through a challenge of running educational sessions while trying to avoid gathering and keeping all of the instructions given to us regarding infection control. And one of the things I faced as an emergency department in in Al Qasimi Hospital that my catchment area changed. I had to cover and support all of the emergencies around me in the region, especially in what we call Zone A, because they had to turn into COVID hospital. So, recovery phase. The question we are asking now, is the pandemic over? Are we really into the recovery phase? Shall we chill? Shall we start giving people, leaves and so on? But we don't know. We are not sure. I'm personally hoping for the best, but expecting a second wave. So I'm preparing the team and taking all of the measures needed so that we are ready if a second wave hits us by September or October. And we have seen a surge in non-infectious cases now. So all of those cases who got delayed over the last few months, now they are presenting to our emergency, and you can see the surge really into MIs and strokes with late presentations. And we are facing now the challenge of how let our team rest with keeping our own regular business. And we are still offering COVID-19 tests in our hospital. So if anybody is still not done the test, they are more than welcome to do it in our hospital. And with that, I end. This was a very new experience to me and our team in Al Qasimi Hospital. We faced many challenges, but those challenges, we took them as areas of improvement, and it taught us a lot moving forward. Overall, it was a great success to the country and to the department that I was dealing with and with MOHAB facilities. And as Dr. Mahmoud said, during this pandemic, the whole healthcare system shined, but one of the two areas that I have seen them shining the most are the emergency and the ICUs. Thank you very much.
Excellent. Thank you very much, Dr. Isam. Outstanding. Just one question raised, I think, related to your hospital. What about radiology department? Were they, because for COVID, the protocol initially was to do a CT scan, and I don't know if that was practiced in your hospital, because I don't, just maybe answer that.
Yes. So once we started to do CT scan as a primary, imaging, we had the privilege of having 2 CT scans in the hospitals. So we made one of them dedicated for the COVID cases or the suspect cases with all the precautions to be taken. And that CT scan will be completely disinfected and cleaned after each patient. So we was fortunate enough to have two CTs, and we use that in our advantage.
Great. We have up to 130 participants so far. I think Dr. Saleh, you can go ahead and introduce the 4th speaker, please, and, so we can stay on time.
Thank you, Dr. Abdullah. Thank you, Assam, for an excellent presentation. This wasn't a surprise. Qasimi and Mohab carrying both hats in a very busy, and I think they were the main hospital in Al Ain. So that's a very interesting experience. Jay, please share your experience with us. You're muted, Jay.
Good evening, ladies and gentlemen. Good evening, friends and colleagues from across the UAE and from the Gulf and the MENA region. And I'm sure some of them from India and others have all been trying to log in as well to watch this program. So it gives me a great pleasure and honor to actually participate in this webinar amongst such esteemed colleagues from emergency departments across, and superbly led by our president of our Society of Emergency Medicine, who's under his tutelage. Even we have started to learn, even though we have come from other backgrounds. It's been a great guide and a support to develop in UAE. So thank you very much, Dr. Salah. And there we go. I'm going to try and present the presentations for Tawam experience. And we took a lot of guidance from the government and societal interventions. We decided we should prioritize early detection. We should try and isolate, treat them aggressively early on, and try and get adequate medical supplies and establish a system in which patients are admitted to a designated hospital, and so that they can get a comprehensive therapeutic strategy. And these were our goals when we decided to embark on this COVID. And I have to say, a great amount of respect goes across to our Italian colleagues who actually dealt with this crisis in a far more difficult manner, but embarked and disseminated their learnings so that all emergency departments and hospitals across the world can learn from their experience and benefit so that we can actually develop and deliver better care. And we went into the yin and yang mode. So for Alain, we decided Alain Hospital, our sister hospital from part of SEHA, would be the designated COVID hospital. But from experiences from Dr. Hessam and Dr. Mahmood, we know we can never clearly say one hospital is COVID and one hospital is non-COVID, because you're going to get a mixture of cases. And Dr. Hessam beautifully illustrated what his problems were being a non-COVID hospital in the Northern Emirates. So we had similar experiences, and I will share. What's transformed? Suddenly, we became the sole emergency department for the whole of Alain region and for about a population of 500,000. So there was no other emergency department for the patients to turn up to. And that itself was going to be a huge challenge for us. So we decided we will call a Code Delta is the team approach, and we call it the Delta Force, which nicknamed it, so that we can bring all the experts from within the hospital team so that we can discuss how we are going to tackle this crisis. And I have to say, really hats off to all the team members of the Delta Force, without whose help we couldn't have successfully mitigated this crisis, as we can see now. And I just want to touch upon what we briefly discussed in this Code Delta meeting. We looked at from the bottom up approach. We looked at, okay, we need to provide personal protective equipment. We also need to bring in some administrative controls. How are we going to think about administrative staff working from home, stagger the schedule of ER doctors, try and make sure hand hygiene is available for doctors, nurses, patients, visitors, everybody. Try and introduce some physical barriers and ventilation systems so that we don't create any cross infections. And for emergency physicians, unfortunately, substitution was not a choice. And Dr. Hessam said we were actually required, and Dr. Mahmood said we were required everywhere, including the emergency department and beyond. And we advised about trying to socially isolate even our own emergency physicians and residents from their own family members, from their loving wives and kids and stuff, so that they don't try and carry these viruses back home. And to a certain extent, it was largely successful. But the key thing is about emergency department is its flexibility. You throw an emergency physician, they will adapt at any given circumstances without batting an eyelid. And that's what I think from a Tawam experience we can say. And I can see from the presentations from my previous speakers that they were equally flexible as we were. I think in the Abu Dhabi, in Sahar region at least, we opened the first emergency department tent to isolate these influenza-like illnesses. We opened a 7-bed capacity one to treat so that these patients will not cross-contaminate into the main emergency department. We also created a pre-triage area so that a registered nurse will direct the mild symptoms to this tent so that they can be seen, treated, and sent home. We had to redesign. Dr. Hessam pointed out what he did with this emergency department, and we had to redesign an ED isolation area for our moderate cases. We had a 8-bedded unit. We brought in the doors to close them as single rooms. We put HEPA filters in. We had separate AC ducting and stuff so that the airflow does not get mixed. And we put in the moderate symptoms, see them, treat them, and then we can transfer them to the designated hospital. But interestingly, we saw a lot more of the adult patients coming in, and our pediatric patients' numbers declined. And more so, we had to change our emergency pediatric department into a second isolation area so that we can cope with the increased demand. Needless to say, we also tried to use learning process using the intubation machine, the corporals that you can see, which can actually do resuscitation with a hands-free approach, both for adult and to a large extent for most of the pediatric patients as well. And I will show you some interesting statistics, because compared to Dubai and Abu Dhabi and other regions where we talked about in Sharjah, where the numbers were decreasing down. Because we were the sole emergency department, you could see from Q1 of 2020, the adult department saw only about 15,000 cases, whereas in Q2, we jumped up to almost 25,000 cases. But contrastingly, there was a 50% drop in our pediatric emergency attendances, which was interesting. And to date, the pediatric volumes have still remained low. But it is interesting to see what's our data with the acute myocardial infarction and strokes. Maybe they were missing Dubai, they were missing Sharjah, they were landing up in Al Ain, which is what I could say, because we doubled, tripled in our AMI cases and in our stroke cases. And I've actually put in some data with regards to our number of positive cases amongst these AMIs and the stroke. More and more of the AMI cases were positive for COVID compared to stroke, where we had only 2 positive cases. And new to us, new to the cardiologist as well, we decided to thrombolize patients in the ER. In my recent research shift, I had 4 MIs coming in 2 hours. We managed to send 2 to the cath lab, 1 to thrombolize, and another one in intubate and into the ICU waiting for it to happen. So things have changed, and we are practicing cutting-edge medicine in the ER. And trauma didn't leave us either. And you can see in 2020, in the orange figures, our trauma numbers also shot up. And these are all that is documented in our trauma registry as supplied. And this goes to show that Tawam Emergency Department was a very, very busy emergency department. So what happened to our ICU for COVID? We had 127 patients in our ICU sent through to us. 58 of them were ventilated. 23 of them had to have renal replacement therapy. And unfortunately, we lost 17 of those patients. And we had an average length of stay of about 6.9 days in our ICU. Yes, we managed to transfer a lot to our sister hospital, but once their capacity became full, we had to expand our ICU, and we actually doubled up our ICU capacity to manage these patients. And just to give you a little bit of our mortality statistics, what happened from January to June 2020, ED, we had 73 deaths. Most of them are brought in dead from outside their unsuccessful resuscitation, but we managed to identify 5 patients as possibly COVID related. And the same 6% manages in the hospital-wide mortality, where we had 384 cases, but about 26 of them, which is again 6% thereabouts, is associated with COVID-related mortality. What sort of an impact it had, other than the change in the layout, the staffing, the opening up of the tents, the isolation areas, and the PPEs? One important factor came in is we were screening our admissions. And this led to a certain amount of delay in admitting the patients, because we know the initial MDX testing was not, turnaround times were not that quick enough. Currently, the rapid test and the antigen test makes life a lot more easier. The other interesting fact is, as Dr. Issam pointed out, the presentations of the patients were much, much later than we would normally anticipate, and they were a lot more sick. And we had thousands and thousands of positive cases that we had to not alone notify the DOH, but also try and contact the patients and to counsel them over the telephone. And I have to say, the residents of Tawam Hospital actually pulled in and helped out and did a fantastic job of counseling the patients over the phone and directing them across to the various places where they need to go to the AHS or to Al Ain Hospital, so that they can get the necessary treatment in a timely fashion. There is one particular challenge which we always had, being a non-COVID hospital, is the limitations to the PPE. And thankfully, due to the leadership of Tawam Hospital, we managed to keep our ED staff from very minimally getting infected. And the nurses were the front line, who actually did most of our sterling work. Is 7% they were affected, and 4% from the emergency physician side. But all of them are well and safe and have returned back to work. So that is great work in between what infectious diseases did with their management. What happened to the rest of our specialties? We had to reduce a number of elective surgeries, including scopies and testing for pulmonology, pulmonary function tests, your CPAPs and BiPAPs, the EEGs and stuff, a lot of them had to be canceled. We had to reduce the number of clinics so that we can pull those clinic manpowers into our inpatients and to the ICU, particularly the general medical physicians. Because we are a big oncology center, and in COVID positive patients, we couldn't give chemotherapy, so some of our patients were affected from the timely treatment. And lastly, we moved into 50% of our outpatients became telemedicine consultations rather than the face-to-face consultations. And we can say from until July 2020, Tawam ED alone tested around 18,000 patients, for including their own admissions as well as for screening. And about 2,600 odd turned out to be positive. The whole of Tawam Hospital per se, along with the nursing team and outreach program, did almost 140,000 COVID tests. And that was a huge number, and ED contributed to the 10% of the total Tawam testing. I also had the honor of actually staffing some of our quarantine facilities with some of our emergency physicians and also physicians from the surgical background, some internal medicine, obs and gynae, pediatrics. They all pulled in together, and I've never seen a teamwork as good as this one, even in my UK practice or in an Indian practice. We opened up Danath Hotel, which had 579 admissions, which is a 150-bedded capacity. We also opened Aldar, and I think Dr. Mahmood showed us rows and rows of buildings, and this Aldar facility had rows and rows of buildings as well. And we reached almost 2,000 patients in that facility before we handed it over to the private facility. In addition, we opened up isolation facilities within our Tawam hospital itself. We opened our female compound, and we opened up the recreation center to hold medical patients in there. And there we added an additional 125 patients whom we treated and discharged them home safely. In addition, we went out to open screening tents, mobile clinics, and only now we closed all our screening tents, and only the mobile clinics is functioning to help some of those patients who still require some testing out, who can't get into the hospital. So the grand total we screened were 145,212, and this is data from February to June 2020. And this is almost 10% of the whole of Seha Abu Dhabi hospitals total number, which was reached more than 1 million, and we tested almost 10% of that. And this is a significant amount of effort put in by the whole Tawam team. But we didn't rest that we have done and dusted with it. We decided we will build something for the future. What we have done, we built an extension building to the emergency department, which has 52 emergency beds and 46 ICU beds, each with ventilator capacity. Should there be a second wave, we can use it, or we can use it for utilizing it as an emergency department with medical and pediatric short stay assessment units and an emergency department short stay as well. So we built something for the future so that we can tackle any other crisis that is going to happen if it has to happen. So on that note, I have to say thank you very much. And I really want to thank the Tawam heroes for their hard work and their humility and strength during this COVID crisis. Thank you very much.
Excellent, Dr. Jay. I think we'll go ahead with the final speaker, Dr. Saleh, can introduce, so we can open the discussion after that.
Thank you, Dr. Abdullah. It gives me a great pleasure to introduce my colleague, Jack Copresi, who's the chief of the Emergency Medicine Institute at Cleveland Clinic Abu Dhabi. Actually, Jack and I met at their conference in February 21st. Amazing day. And honestly, thinking back, no one expected that we're going to dive into this pandemic, but things do happen. But they definitely have an amazing department, amazing team. They are, I think, the highest qualified emergency department in the country with 24 hours consultant coverage. We're really honored to have them with us here in the country and with their contribution to the community. Dr. Copresi, if you can share your amazing experience with us, please.
Thank you, my friend. First off, I want to start by thanking the new Emirates Medical Journal, EMA, ESEM, and my wonderful colleagues for inviting me. It really is a delight to be here. I wanted to share a few things, and being cognizant that I was the last speaker in the queue, I didn't want to repeat too much of the amazing things that others had also endeavored to do. And I really wanted to reframe the conversation a bit to put kind of an exclamation point and a bit of a conclusion to the things that we've been through and the way we can prepare for something in the future. So to that end, I prepared just a couple of slides to illustrate that. Great. So the first thing is, you know, in the midst of this very unpredictable, difficult time, when things are coming at you at, I was going to say 60 miles an hour, but I guess I should say 100 kilometers an hour. It was important for us to try to make sense of everything in a way that we could comprehend and we could assimilate. And I started to think of categories that I would call the 4 Ps. And what I mean by that is, first, you've heard from everyone how they've reworked and redone their policies. So figuring out how to ensure physical distancing, figuring out how to develop swabbing criteria, who should be swabbed, who shouldn't, changing in visitor policies and restrictions, both for their own safety as well as caregiver safety. The second P, what do we do for our patients? Is this going to have a positive impact? Is this a value add for patients? And I would think of those things as, when we create these split flows, reverse isolation areas, in the same effort to remain humane and to give people compassion. And other elements of emergency departments, for example, tents, separating patients with symptoms versus non-symptoms, and then trying to use the best evidence-based medicine treatments, whether it was hydroxychloroquine in the beginning, monoclonal antibodies, proning in the ICUs, etc. The third P for us was, what do we do for our people? And they're just as important as anything else we were doing. So ensuring that they have appropriate PPE, that they know how to use it, and we're constantly training and retraining them to try to make sense of this and ensure appropriate communication and information is going out, while at the same time being cognizant that the situation is not changing week to week, it's changing day to day and sometimes hour by hour. So how do you filter out some of those pieces of information and data that you know are about to change, so as not to confuse people and make them even more frustrated than they are? And then, of course, providing people emotional support. We know this is very taxing for all caregivers in the hospitals, and giving them those resources. Everybody was in contact with friends and family and other healthcare workers that they're close to in other countries, and hearing their concerning stories obviously was affecting us and our team as well. So that was definitely a priority. But the one that I really want to focus on for the end of this is the preparedness. And I think this is incredibly pivotal, not just during a pandemic, but for emergency departments everywhere. I mean, that is the hallmark of being an emergency department. You might not be a trauma center, but you better be ready for anything that comes through your doors, right? And that is part of what makes us excellent emergency physicians. And preparedness is the emphasis, and it has a couple of different parts. There's the before, there's the during, and then there's the after and the future state. So, for example, a few unique things that I thought was special about Cleveland Clinic Abu Dhabi during this is, we were very blessed to have a COVID task force chaired by our chief nursing officer and our chief medical officer that met every day through this entire period, and was made up of every entity that you would need to handle a prolonged crisis like this. Not just clinical and nursing, with ICU physicians, ED physicians, infectious disease, occupational health, figuring out how to isolate caregivers, et cetera, to help them. But the facilities people and operations, when we're reconfiguring the EDs, creating walls, et cetera, figuring out entrances, erecting tents, they were necessary. Security, for example, every individual section that we were going to need to be successful, and they met every day throughout, which was amazing. Another thing that I was really impressed with, and as somebody who loves data, I was really, this was like a Christmas present to me. We created this COVID dashboard that was a one-page visual, refreshed daily, that gave you a awareness of the entire hospital, what we were doing, where everything was. So for example, at the top, it had all the data for worldwide COVID cases, both suspected and recovered deaths, UAE data below that, and another section for our caregivers. So every single caregiver category, physicians, nurses, allied health, contracted, etc., was listed. How many of them were infected, how many were recovered, how many were quarantined, how many were back to work, what our call-ins were, what our available workforce was, every room and floor in the hospital, how many beds were available, how many were occupied, which were COVID, which were not. All of our equipment and supplies, and this is not just, you know, N95s and gowns. This went all the way down to ET tube holders, oxygen cylinders. We knew how much stock on hand we had. We knew what the capacity was based on our usage, but when we'd run out of that, it would show when the next shipment is planned, and we could easily see where the pressure points were. And then, of course, medications, our supplies of hydroxychloroquine, monoclonal antibodies, antivirals, etc. And it was all there in a very easy to see pictorial, which was amazing to me to see, and the power that that gave you to figure things out and to treat them most appropriately. An example of preparedness that I wanted to bring is South Korea. And everybody, I think, is aware that South Korea did quite a good job. And part of that is because they learned from the past mistakes. So about 15 or 18 years ago during SARS, and then more recently in 2015 during MERS, they realized that this pandemic has a potential to occur at any time. And in the past, they'd had some issues with not being candid with the population. They fixed that with transparency laws, with prompt electronic alerts, so that when COVID came, the amazing thing with South Korea is they were able to activate these centers, these policies, these laws, these rules preemptively before they had their first case. And they were ready for it when it came. So as COVID became more of an issue, they were leading examples of widespread testing everybody, not just symptomatic or sick or patients who are hospitalized. They were able to ramp up their production quickly. One of the rules they had made was that labs were allowed to use testing bodies that weren't necessarily accredited because it was a public health emergency and they're trying to get as much information as they can. Drive-through centers for testing, contact tracing using technology, closed circuit TV, geocentric location, and then very prompt encouraged/mandatory isolation, mass testing, tracing, and isolation. So South Korea for me is a hallmark of how to do this correctly. But to be honest, I think that the UAE as a whole did just as well by following some of those same rules and regulations. When you think about how aware the government and the Ministry of Health and DHA and DOH were, I mean, they were closing the schools, closing the borders, closing the mosques back in March, right, before this became a big issue. The quarantines overnight, the disinfection, I think we did an amazing job for something that could have been much more hard-hitting to the citizens here and the residents. And I think that we should be very proud of how we reacted to this as a country, as a unified whole. And then as a proponent of technology, I just want to plug the use of technology for the future, whether it's a second wave or a different type of virus that comes along, for artificial intelligence and early warning systems as an opportunity to let populations and departments of health know well before human clinicians can figure out there's something strange going on. This gives us a lot better handle and a lot better care for these epidemics and pandemics before they really set hold. So I think we've learned a lot from this. I think we should apply these lessons. We shouldn't forget this and go back to normalcy. And obviously, I think that there are bodies like this and communication discussions like this that will ensure that we do so. So thank you very much. I tried to be brief and give you just a bit of an overview of some things that we had done and some of my thoughts, and I appreciate again very much being here. So thank you.
Thank you very much, Dr. Kobersi. So let's all join and to discussions now. So, Dr. Saleh, since you are the president of the society, and one important question for our residents and fellows is what happened to their training?
Yes, it's a very important question, and I think surprisingly, actually, we all thought that the direct impact of training will be suspending training, suspending academic days. But I personally believe that what they've learned during the past couple of months, something that they will always change their career, they will change their skills and practices and confidence. So yes, although many of the residents did not meet for their usual and routine training, but I think life and real life taught them more than what they need. So I personally see it in my own residents, and a lot of them played a leading role. They practice in real ICU time, in real emergency department peak. So they've done a lot of procedures. So I think it was helpful in their training, but not the classical way.
So the question goes now to Dr. Assam, Dr. Mahmoud, and Dr. Jay. We'll come back to Dr. Kobersi at the end. You mentioned in your data that number of cases, stroke, MI, reduced. We know what happened to the people at that time. People, the activities reduced. There were a lot of restrictions of their activities, and people remain at home. Do you think this is a reason, or something else could be a reason? Is it the fear coming to the hospital? What I mean, you guys see accident, you see critical, medical, surgical, many things. But what, in your views, what do you think the reason for that reduce? I mean, apart from these restrictions, anyone can start.
Yeah, let me. Actually, maybe we are quite peculiar among other emergencies and hospitals because the main bulk of our clients are, that employees, and most of them are laborers who are living in camps, and to come to the hospital is not that easy. It's not just a simple option. You have to talk to your foreman, and the foreman will arrange a car. So what we think that it was difficult to come. And number two, not everybody perceive restrictions as we thought. So laborers cannot go out when it is just the movement is banned. They're really afraid. So don't take it easy. But now it is time actually to calculate the risks which happened. Now let us see how many honestly, maybe the dead on arrival is an indicator, but I will not take it as much because there are so many dead on arrival who comes who are young and with no risk factor. So we don't know really, we don't have autopsy to know what they died from COVID-19 or its consequences. But now we have to say whether we can see more of heart failures, we can see more of complicated strokes, we can see more of diabetic who actually are really sick because they passed critical areas. Now we are calculating the risks. But I think honestly, why the decrease was because it was difficult to come to the EDs.
Prof, I think in addition to that, there was, it was a multifactorial probably. Yep. And one of the things I have seen it myself, whether it's among our relatives or the patients I've seen in the emergency department, is that they had the fear of going to the hospital when they had symptoms that might be to them as a minute. So somebody who had a little bit of chest discomfort or nausea and so on, they would ignore it. They prefer not to go there because there was the fear of like catching this COVID-19. So there was for sure a delay in seeking care, and also in addition to that, ignoring their own healthcare plan to some extent. Like many patients, they started not taking their medication or not follow what they were supposed to do, and so on. So I think it was multifactorial, but for sure one of them was a delay in seeking medical care.
Dr. Jay?
I'll have to agree with both of my colleagues. I think it was multifactorial, and we could see his access to restrictions from travel point of view. They didn't want to come into, and when you ask them, why did you present 3 days later? You have had a heart attack, and they say, oh, I thought it was just a niggling pain, and we thought it will go away. I drank some Gaviscon and stuff like that. And the last thing is, they ran out of their medications, and they couldn't go and find the medications to refill themselves as well, because access to a lot of the facilities were not as easy as before. And so I think it's multifactorial. But surprisingly for us, our numbers went up because we became one facility, so our numbers went up. So that's the slight oddity in this thing.
Dr. Cobers, you know, we learn from Italian, we learn from UK, maybe US, but what we learn from ourselves, you know, what do you think, you know, in terms of protocols, in terms of for future? We don't know what's going to happen in future. I mean, we hope, you know, things will disappear, but what we learned so far from UAE experience?
So I think that, as I said, I think the UAE did a fantastic job making sure that we took lessons from other countries, such as Spain, such as Italy, such as South Korea, and some of the Asian countries, and applied them here in the way that they do to harness the best evidence and technology in order to provide the best healthcare to their citizens and residents. But, you know, we should not have done any less, right? We had all the warnings. The other countries who are at the forefront of this in January and February, who really suffered before the world knew what this was, had it much harder than the countries who came later, like the UAE. I think the main teaching point from this is everybody, after a disaster or a hurricane or the COVID-19 pandemic, they want to take a breath and relax and get back to normalcy and get some semblance of what they had before. And I think that would be a very unwise thing to do right now. We need to be prepared for a second wave. We can't let down our guard. And we need to be prepared for the next virus that hasn't been created yet, that we know will come at some point.
Great. Okay, well, I'm just, we're last few minutes. There was a question about, I know this is relevant to not just to ER, to all the physicians. We have restrictions of, the medical doctors and staff to travel, but is there any other way of, you think we can help our physicians while emotionally, and I mean, I don't know, I mean, you are ER guys, you see everything, and you are expert in everything, and you see everything, and so you need some relief. Everyone needs some relief. What's the way forward for managing? We have restriction movement outside, but what can we do? You think? There's a question from one of the colleagues. What can we provide for our staff?
I think I can briefly talk about this. Part of our recommendation on the position statement that we recommended is the mental health of the emergency physicians and the emergency providers. Based on the experience that we have, I think understanding that this pandemic is a long-term should really, especially us as administrators and chief of departments, should understand that we should prepare the teams not for a short term. It's not a trauma. It's not just a building collapse, but it's more of a pandemic that goes on over months. So making sure that the staffing, and this is what the government, alhamdulillah, supported by reducing, this was intentionally social distancing, but actually a lot of it is mental health. A lot of the working hours were reduced, the shifts. Of course, we as emergency physicians and emergency community suffered with the shortage, but we have to admit that we did, at least in our facilities, we did have support from other specialties also, so we were not left alone. This means that we need to take time off. We need to really be able to reduce the stress on our colleagues and on ourselves, and be ready for a longer game. This is, I think, what we learned and what we advised as ESA.
Yeah, I think I see that the beautiful, as everyone agreed, the model of UAE is really encouraging and really lots of hopes. Number of infected, 59, those who recovered 52, 6,000 or 6,000 are active. So we have more, died 345, so mortality around 0.5%, 0.05. It's very, it's very low. So compared to worldwide, and I think all the regulation done in the country really is had its bounty. And I just want to say a few words about our journal. This is our Emirates Medical Journal. We hope it's to be indexed in 3 years from now, to be impact factor in 5 years. We've launched this in January, and you can see it's really through these kind of activities, through your case report, through your original data, we accept all these, and we have our online. This is our online. You go in and to see what's how the author to direction for authors. And we've received 146, and our acceptance 29 really accepted. And we had the first launched in January, I said, and we had first story on COVID in January before anyone else talk about it. And we had a survey among our doctors about the COVID awareness. People talk about awareness, so we check that among our doctors and staff. We were surprised, to be honest with you. That was in March. It was quite low. People had funny scientific knowledge about it, but I think it's grown now, it's improved. These are our support. Support come through you, as authors, to publish, through government, from pharmaceutical companies to help with publishing and helping with writing papers. So it's really through the publishing we can, it's like a passport for us in the community. I just want to hear last few words from each of you, 30 seconds. We'll start with Dr. Saleh, you, and what's your anything you want to say? Just 30 seconds, please.
Honestly, I have nothing to say but to thank my colleagues from the different sectors, physicians, nurses, allied health, the paramedics. Honestly, the emergency community was really stood up, took the lead, took the challenge. And I think, as Dr. Mahmoud mentioned, yes, we did shine as a specialty. And we're doing and we're communicating just to make the response better in the next, if there is, inshallah, nothing happens, but in case something happens, the response will be, inshallah, better. And thank you for hosting such an event, and thank you to EMA for hosting us.
Pleasure. So Mahmoud, please, your words.
I changed the definition. Who is the hero during this pandemic? It is not physician nursing. It is each single citizen or resident in UAE. Everybody is a hero. All of us shared our success, and alhamdulillah, I am very optimistic. I think we made it, and we are ready for anything now. We passed the most difficult. We are more strong. We are more confident, and I'm really, really, really proud that I am practicing medicine in UAE.
Excellent. Outstanding. So, Hassan.
I thank you all for being here today, and thank you for inviting us. I second what Dr. Mahmoud said. I think we are very proud of being part of this community, and very, very proud of our citizens and people who are in the UAE who participated. I will 3 brief points. One, I think disaster management should be really focused on in our residency programs, and our residents should be really prepared, because the way we were prepared for things helped us a lot. I think preparedness the way they taught us was really the first thing that will help us through any disaster. So the more prepared we were, the better is our response to any disaster, not only the pandemics. And very, very special thank to my team and all of the teams in all and each of the emergency departments in UAE, and all of our colleagues who actually helped us fight this pandemic.
Abdullah, you're muted.
I'm sure it's you, Jack, if you will allow me.
Reading his lips.
Yeah.
In closing, I just want to say a couple of things. Again, thank you to everybody who had us. Thank you to my colleagues. I learned some significant things here that I think will be helpful for us and our team in the future. And just as a plug, everybody has talked about how wonderful emergency medicine has performed and has proven its worth. And I think, to be frank, everybody on this call, every emergency physician that you are contacting in the UAE and you need to get them involved. You need to get them in EMA and ESEM, so that when we do have these issues, we collectively band together stronger than any one and come out victorious. So one thing I learned from this is that fragmentation in pandemics doesn't work. It has to be unified. And organizations like ESEM is the best font for us to do that. So everybody listening, there's 130 or so at some point. You make sure every colleague of yours has signed up.
Dr. J, please.
So I would like to thank all my colleagues who are in this program and those who are watching us. And I would take this opportunity to thank the UAE leadership as well as our SEHA leadership for actually helping us a lot through this crisis. It's been a lesson, a lot of lessons have been learned, and there have also been a lot of success stories. And as Dr. Mahmood pointed out, every single citizen and expats in this UAE are all heroes, and I completely agree with it. We've learned a lot and we've worked together. The one important thing which I found for the success for this way we mitigated this crisis is communication. And there has never been a better time where we have communicated so well as we did in this period of time, and may it continue or in the future. Thank you.
Great. I think, we are speechless for your kind of activities and your roles, your humbleness. The amount of work you've done, adaptation you've done, and you remained, positive and leading by true example. Really to thank you on behalf of, again, Emirates Medical Association and Emirates Medical Journal for giving us this opportunity, Dr. Saleh and your team. Outstanding, wallah. I think all of us learn a lot, and and the hope and I think future is bright. Thank you very much, and stay safe and healthy. Assalamu alaikum.
Thank you, Dr. Abdullah.